afternoon, and welcome to the DEBAKEY CV Live Studios. We have a special presentation this afternoon from the International Society of Endovascular Specialists, and it's about women who've made a difference. And I'm delighted to be joined here by two of the officers from the International Society of Endovascular Specialists. The president-elect was Ourania Preventza from Texas Heart Institute. And I'm going to hand it over now to Palma Shaw. She's the secretary of the ISEVS, and she joins us from Upstate New York. Palma.
Thank you, Alan. It's a great pleasure to be here today. We've been so excited to have this session. We'd like to really honor women who are really leaders in research and in their field. And we want other women and other specialists in vascular care to understand that there are women making these wonderful contributions. And I'd like to introduce some of the women that are here today. It's really a great pleasure to introduce Kak Khee Yeung. She's a dear friend of mine and actually incredibly successful as the research director and principal investigator in the vascular surgery at the VU University Medical Center in Amsterdam. Her main area of interest is clinical and academic research in the field of aortic pathology, endovascular surgery, arterial disease, and new treatments and techniques for abdominal aortic aneurysms and aortic dissection, as well as peripheral vascular disease. She's now appointed as a scientific council member for the Dutch Heart Foundation, Young at Heart. She's done many different fellowships in Taiwan, in Albany, New York, as well as in Rochester, as well as in Amsterdam, and has completed her PhD at the VU University in Amsterdam. And her thesis was juxtarenal aortic aneurysms, aspects of treatment and reduction of postoperative complications. She's had many certificates of excellence for her research. She's presented and been recognized by multiple leaders of the field. She's the associate editor for the Journal of Endovascular Therapy and part of the editorial board of scientific reports in Nature. She's a key reviewer for the Journal of Vascular Surgery, awarded top 15% reviewer, and the European Journal of Vascular and Endovascular Surgery. She's a member of many professional societies, including the International Society for Endovascular Specialists. She has many different grants. She oversees numerous postdoctoral fellows in her research laboratory, and she's on tenure track program for full professorship. We're really very happy to have her here today. Thank you, Kak Khee, for joining us.
Thank you, Palma.
I'd also like to introduce Trisha Roy, who's with Alan in the studio there. She's a new partner for Dr. Lumsden at the Houston Methodist Hospital Center. Trisha wants to transform the way we plan and perform endovascular procedures using novel imaging techniques. She's a vascular surgeon and engineer and completed her PhD in medical imaging at the University of Toronto in Canada. She in fact developed a new method to image occlusive peripheral arterial disease using MRI. And this imaging technique is flow independent, does not require exogenous contrast, and has the ability to characterize the morphology and mechanical properties of peripheral arterial lesions. She has successfully translated her ideas using the mechanistic insights and deeper understanding of peripheral artery lesions to develop the cath pilot steering catheter and co-founding a company. She is now a clinician scientist at the Houston Methodist DEBAKEY Heart Hospital and spends 50% of her time devoted to vascular surgery and 50% to research. She plans to further develop MRI techniques to improve prognostication, guide appropriate endovascular wire and device selection, and invent novel therapies for peripheral arterial disease. Thank you, Trisha, for joining us.
Thanks for having me.
Thank you, Palma. And I would like to introduce Dr. Hanneke Takkenberg. Hanneke is really a great friend of mine, as well as a great role model for me. Is a professor of clinical decision-making in cardiothoracic interventions at the Department of Cardio-Thoracic Surgery in Erasmus University Medical Center in Rotterdam. After obtaining her medical degree in Amsterdam in 1994, she worked for 2 years as a research fellow at Sinai Department of Cardiothoracic Surgery in Los Angeles. And then she returned back to Netherlands to pursue a career in clinical cardiovascular practice. To say a few of the accolades, in 2002, she obtained her PhD in cardiovascular clinical epidemiology at Erasmus University in Rotterdam, and started her research group in the Erasmus Medical Center. In 2005, with her collaborative spirit, she co-founded with the cardiologist Julian Ross Hesselnick the Erasmus Network of Academic Women to address the gender imbalance in her own institution. She actually served as a Chief Diversity Officer at Erasmus University since 2015. And since 2018, Professor Takkenberg is chair of the Dutch Network of Women Professors, representing more than 1,500 Dutch women associate professors in the quest for a proportional representation of women in Dutch academia, equal pay, and safe academic working environments. In 2018, she joined Rotterdam of Management as Professor of Management Education and Executive Director of Erasmus Center for Women and Organizations. And of course, if this is not enough, Hanneke is really a scientific leader in the field of heart valve disease, and she is the past president of the Heart Valve Society, a meeting actually that I was very glad to be 2 years ago, where Hanneke did a fantastic job. So it's really my distinguished pleasure to have her as one of our guests today.
Thanks, Ourania.
Thank you, Rania. So we really just wanted to have an interactive discussion. We want from all of you your insight regarding various aspects of your training, how you got to where you are, how it may have differed, all training at different time frames and with different backgrounds. And so we'd be love to hear really what was your path, how did you get there? So Hanneke, maybe you might comment, you mentioned earlier a little bit about your path and some things that you felt were helpful to you. Would you elaborate upon that?
Yeah, sure. Yeah. So when I graduated from medical school in Amsterdam back in 1994, which is like ages ago, I think, what I did is I made a phone call because I wanted to see the world. And that phone call happened to be to Cedars-Sinai in Los Angeles. So I think that's where it starts, with your own ambition and dream big, and then also act upon it. So I was welcomed very warmly by Alfredo Trento and his team at Cedars, and I spent 2 amazing years there that showed me my love for cardiac surgery on the one side, and on the other side also my love for research that eventually made me choose for a research path in my career. And I must say, one of the decisive moments in my career early on was actually on the steps of Cedars on a Monday morning when I came back from a procurement, because I was also in the transplant team. And I met one of my female colleagues who also had been on call, and I told her, "Oh, you're going home as well?" And she's like, "No, I'm staying here. My husband's driving by with the car with my 2 kids, so I can kiss them before I go back to work." And that was for me something that I realized, hey, is this the life that I want? And from that moment on, I realized that the challenges that we have as women in this field are quite complicated. And I'm pretty rebellious, so I wanted to do something about it. And I've been continuously doing that ever since.
That's great. Kak Khee, why don't you tell us a little bit about your background?
Well, I agree with Hanneke that it starts with your own ambition and with your passion. So when I first saw Professor Wisseling, he is a vascular surgeon in our department, the head of our department, I was like, yes, that is what I want to do. And from that moment on, I just pursue every chance that I could, go on the OR. I did research, but it was more like a passion, not like that I wanted to become a surgeon, but more like, I really like research as well when I got introduced to it. So at one point I just, after that I went to him. I was 19 years old at that time, so I was really young. And I went to the OR, and the one thing I did was only actually, because I just want to see the surgery, I was playing he was doing robotic aortic surgery, and I was just pushing the play button for him to tape everything. And that was my only role when I was 19. But I really liked surgery and also liked the research part. So I started to assist his PhD students. And then when I was, I think, 20 years old, I thought, hey, I can do that also myself. And they were all actually male PhD students and male surgeons, of course. So I was like, okay, I can do that also. So I started, he gave me a subject about juxtarenal aortic aneurysm. So it was like, okay, how can we improve the surgery for juxtarenal aortic aneurysm? And I thought about it, and then we came up with renal cooling during these aneurysms. So like, because you use that, you have to do suprarenal clamping, and then the kidney doesn't have any blood. So how can we preserve the kidney? By perfusing it with cold saline or something. And I have performed these studies in the lab in rats first, and then we did some patient studies. And from that on, I really loved also the research and the physiology, why diseases were there, why it happens, and wanted to understand everything. And then I started to make a biobank of aortic aneurysm patients. So I was at that point 20 or 21 years old, and I started to collect tissues from all aortic surgery and patients. And now we have like 700 of these aortic samples. And I also did, 6 years ago, I started to make these samples. I didn't want to freeze them. I wanted to have a cell culture so I could build an aortic model, which was live. So a live aortic in vitro model based on patient cells. So right now we have also over hundreds of smooth muscle cells and endothelial cells of these aortic aneurysm patients. So my passion started actually by loving aortic surgery and of course vascular surgery a lot. And from that on, I just, got the drive, and I just work. And I thought, if I work really hard, I always will get there. And then I became a resident, of course, and then a lot of fellowships. And then I became a vascular surgeon. 50% of my time is also spent to research, and 50% of my time is clinical work. So that's basically from how it started. But all started with a passion for vascular surgery, really. Yeah, and for research I wanted to understand the disease, why, and why are we doing this to our patients, and what is happening, and I just didn't want to cut out the disease or treat it like because you're always harming a patient if you do surgery, of course. So I wanted to understand why do we have to do that, and is there an other way? So personalized medicine and these things are more, my path. Yeah.
Thank you so much, Kak Khee. Trisha, why don't you give us a little bit? Your background's really fascinating as well with imaging. Can you tell us more about that?
Yeah, I think that a lot of my path forward is kind of defined by not having much of a roadmap to go ahead, because I've been the first to do a lot of these things. So I trained at the University of Toronto, and I was the first year of their integrated vascular program, so they hadn't had one before. And it was also a surgeon scientist program. So you do your junior residency, you step out, do a PhD, come back in, finish your training. And it's a pretty unique program in terms of, your ability to combine training in surgery, but also have really dedicated training in your PhD of choice. So I came from an engineering background, and my PhD was in MR physics, developing new techniques for that, and also device design is kind of an interest of mine. And now that I'm here at Houston, it's I'm a clinician scientist. This is also a fairly new program as well that we're trying to really develop here. And so just being willing to be the first of something, or not have a ton of role models to go forward, but being willing to just try and give it your best and opening up the doors for others to people to follow. I think that's really been something that I've tried to do throughout my career.
Palma, can I ask you a question? So,
Yes.
so my daughter is in medicine, and it's as a surgeon, yeah, it would be nice if she was a surgeon, but she decided to go into anesthesia. And although I tease her unmercifully about being an anesthesiologist, I'm kind of relieved, to be honest with you. I think it's better for her long term, and better for her. I think women who choose to go into surgery choose the hardest path imaginable, and you're faced with so many incremental problems. Again, I think about an anesthesiologist, work side by side in the operating room, have set hours, they come in, they can walk away. We have no set hours, no such thing as set hours, and it compounds this ability, particularly around family life for all of us. It doesn't matter whether you're male or female, but I think it's particularly challenging for women. And I'm really interested in how people try to balance those things.
And actually, you just brought us into the next subject, because that was an excellent introduction. I think I would like actually to meet your daughter, and I would like to coach her, if you don't mind.
Sure. She just took a fellowship at MD Anderson, so she's coming back from UCSF, and we're very happy.
Exactly. So I think we have to spend some time with her. But actually, really, this brings us into the next question that is extremely important, that we touch on, the ongoing challenges for women in the as cardiovascular surgeons, including cardiac and vascular. And of course, I'm in the US and Palma the same, but I would like to see Trisha, Hanneke, as well as Kak Khee, to see what are the ongoing challenges that at least for Trisha in Canada, and for Hanneke and Kak Khee in Netherlands, that women have.
Yeah, well, perhaps I should start, because there's quite some research into this as well, and I can also talk from the experience. We've done some research in my network for women professors in the Netherlands, asking about the safety of working environments for women, both in universities and in university medical centers. And that research really detected a couple of patterns that are actually causing women not only to have less chances of advancing in their career, but also causing unsafe working environments. And I do think that these are the main challenges we face right now, not only in the Netherlands, because we also see similar research elsewhere. And that has to do with the way our system works. And I do truly believe, Kak Khee, as you say, and I agree, it all starts with your own ambition, but you are entering a system that has been very competitive, very hierarchical, very much organized in a way that it makes it difficult for people who do not comply to the standard to make a chance. And I would so much like to change that system for the better. And the only way we can do that is by being ourselves, but also work on changing the system and work on the way we value the surgeons, clinicians in general, and also scientists. And that's a big challenge, because it's been like this for ages, of course, and I guess it's the way we've become to find it very normal. And trying to find solutions for that, that's a difficult thing. That's what I notice. So that's the main challenge.
When you say it's unsafe, can you give us an example? We work with radiation, and we tend to think of radiation safety, but are you thinking of sexual harassment in the workplace environment? What exactly are you talking about?
Well, I would talk about, you can call it harassment, which I think is a really big word. And harassment is not only sexual harassment, but it's also in being excluded, in being bullied, in being verbally and physically abused. In science, we also see a lot of theft, not being able to earn the spot in the author list on certain papers. That sort of stuff. So it's a wide range of things. And you can also include microaggressions. These are things that happen that people usually don't even realize that they really put people down. So having more awareness of that, of the effects it not only has on the person in question, and of course harassment is a broad thing. It affects both men and women. It affects
Absolutely.
women.
I mean, you just you just said something right now that Alan brought. This is extremely important. You know, you start with something that is microaggression, right? Means maybe nothing, and then ends up to be something like serious, and can be from even you get involved in a study, you're involved in a paper, and then you're not the one, presenting, or again, like people ideas. So I think this is, as you said, is like a huge subject and very broad. I mean, Trish and Kak Khee, what do you guys think regarding the ongoing challenges that you have?
Well, I want to comment on that. There is a lot of microaggression. I agree with that, but I don't know. Maybe every person has to deal with that, even if you're indeed a male person. So I think that is for everyone. But what I learned from all these years is that indeed you have to stay true to yourself, but also to speak up. So if something is happening that you don't agree, then just say to the person or to the one who is actually showing the aggression, something is not right here, and you have to speak up. If you just let it go, and every time you just let it go, because if you're a resident, I saw that I had to deal with that a lot, and I let it go usually because I was, in a different position. But right now I'm a vascular surgeon, and I could more easily speak up. So for residents, it's even more harder. So you have you have to deal with vascular surgeons, male vascular surgeons also, and you are also a little bit insecure about your own challenges that you have to look at also, and how your operative skills are, and a lot of uncertainties already in that age, because you're 20 to 30 years and you're developing as a woman as well. And then you have to deal with also these microaggression things. You can't. So then I was just like, okay, just fine. I will just listen to it and then nod, and then, okay, I just go further with my own thing. And sometimes I agree, but usually it's just, I don't agree, but I just let it go. Because sometimes they told me like, oh, you're speaking too loud, you sound like a bitch. Because that's easily what people say to you. But and I let it go. But now I don't let it go anymore. I'm like, if I taste something like, oh, there's a little bit of aggression, I just speak up. I just say, oh, is this something that you don't like about me? Just tell me, I can do something about it. So it's a learning process, how to deal with all these things. And I'm not sure if you can do it when you're 20 to 30 and a resident or a fellow, but when you're a vascular surgeon, I still have these things, but now I speak up. And I also see my professor sometimes when they have a very hard procedure, complex aortic repair, which I've done a lot, but new people come in and they just, say, oh, he can do it or he can do it. But I'm like, oh, I can do it too, But then I just speak up, hey, I can do it too. So, yeah, you always have to speak up.
Trish, what do you think?
I think that in some ways we're a little bit behind the US and Canada. So when I started the program, I was the only woman out of, if you count international and all our fellows, out of 19 trainees. So that already feels like you're a little bit on the outside trying to work your way in. And I think that there's like a concept of if you see it, you can believe it or be it, and not having that representation does make it hard, right? Because all the things that you're talking about, I want to have a family, I want to have a life, I want to have a full career. But if you haven't seen any women who are doing that, then it makes you feel like maybe that's not possible. And I think that that's been the most challenging part. It's changing, now at Vascular in University of Toronto, they've hired 2 new young women and it's building. But as we're going through, I find that really challenging. And the thing that's actually really supported me through has been male mentors who are really forward thinking, and my husband's a surgeon as well, and he's very, very supportive. And because I think that there's a lot of times where you might have self-doubt as you're going forward, and not having a concrete example of what that's going to look like is kind of scary as you're going forward.
Wow, I never actually would have thought that Canada is behind US.
Yeah. But these are just challenges on the work floor, but also at home you have to deal with these too. So like friends and family and everyone around you, you know, they just, you have a job that is also, you know, as hard as my boyfriend is actually, but it's the family and everyone is less supportive about it, because they just think that the female person has to cook at home and has to do the wash and the dishes and everything. But, you know, it can also be the other way around. And I'm convincing my boyfriend that I can do it, I'm going to plan it differently because I'm a very good planner. Mm-hmm. So the stereotype, you also have to deal with it at home. So it's not only at the work floor, but at home you also have these thoughts about and challenges about being a woman that has a career. Yeah.
Palma, can I just remind the viewers that there's an opportunity to send in questions. This is a spectacular discussion. I can't imagine there's not a lot of questions out there. And you can either send them in by the web, and these banners are running across at the bottom of the show. By web, it's to poll.com, enter DEBAKEY, and then it'll guide you through it. Or you can do it by text message. You text DEBAKEY to 37607. That's DEBAKEY to 37607. We'll see the questions, and I'll help moderate the questions for this panel. Thank you.
So I wanted to say that I guess I'm in the middle as far as my career, and I trained in a very abusive surgical training program, and I think that there's a tendency for a lot of women, we get used to the abuse, and then like Kak Khee's saying, you should speak up and stand on your own 2 feet. And I think that the younger generation of female surgeons, honestly, believe it or not, they are not in the same situation that I was in and my peers at the time. I don't know, Ourania as well. So, but I do think it's changing. I think I'm very optimistic about the way things are going. I think that the leadership, like Alan Lumsden here and many other leaders in vascular surgery, and I think in cardiac surgery, are really trying really hard to understand, because they definitely don't understand women. They're not Mel Gibson in that movie where what women want. I mean, that would be great. But maybe Alan, but others not. So anyway, but I think that I'm just very optimistic, and I feel that with all of the women that are bonding together and trying to support each other, things are going to be much different in the future. I think that many times a lot of this is we fall down and then we think it was us, but it's not. It was just a circumstance. You have to get back up. And I think men do have a lot more support than the women, and I think that makes a big difference. I think that with enlightened men like Alan and other male leaders in vascular surgery, and the women that are moving up in the ranks, we're going to be in a different place. So I just wanted to express that.
Yeah, well, that's what I think, and it's in the answer, of course, to these challenges are both in increasing representation of women, and at the same time also making sure that we support each other, because Kak Khee, if some type of harassment happens to you, I cannot expect of you to stand up for yourself because you're being a victim. I do believe that it's important that the people around you stand up and speak up. And I think that is the most important other thing, besides representation, is also showing support and telling other people that this behavior is not correct. So I do want to stress that, because that's something, it's very hard for a victim to stand up.
That's true. But the hardest thing is also that the person that you have to tell it to, that he or she doesn't see it. So that is very hard to deal with that. So that's why now I prefer to speak to the ones who show the aggression instead of going to my superior or someone else. Mm-hmm. But if it's going on for a long time, then it's different, of course. But you have to deal with it, I think, as a female surgeon. for a long time. I'm not sure. I'm not sure when the environment will change. I don't know, Hanneke.
Yeah, no, and of course we're in the Dutch setting, which is very traditional. You may think we're all very liberal, but when it comes to family values, it's very 50s, I can tell you that.
Yeah.
But it's actually the reason why I took on a second professorship, because I wanted to do something about it. So we're actually creating workshops for example, medical centers and for universities on how to deal with this as a community, rather than make it the problem of those groups that are not affected by it. And I find that very gratifying, I must say.
Yeah, also the workshops that like how women should do leadership and these kinds of stuff is all again that I have to adjust. So why are the other people not adjusting, you know? So I don't want to follow any workshops how I should be a female leader. I just want to be a leader, and they also have to just listen. While if I'm a male leader, they also listen. So why should I have to follow a female leadership course? So I'm just, you know, it's the other way around. We have to adjust all the time.
We have to adjust and contribute in a way. I have a question for you guys. So we have to change a little gears and ask you about, you know, currently there's a lot of cardiovascular clinical trials, and all of you, I think, you have been involved in this. And one of the issues is that a lot of the conclusions based on these trials are really, you know, we have over-representation in these trials of one sex versus another. So the conclusions that we make are maybe kind of biased. And based on these trials, where you can have underrepresentation of women, for example, as patients, we end up having expert consensus and we make guidelines. So I would like to see your thoughts about your women leaders in cardiovascular and cardiovascular arena. How, from your perspective, you try actually really to eliminate these disparities and make sure that, you know, during the conduct of a trial, we have equal representation, or there is an equilibrium, because by the end of the day, it's really like better patient care. So can you a little elaborate on this?
Absolutely. Yeah, I think it's one of the big issues of our time is that we're being very much guideline driven. At the same time, we have suboptimal insight into male-female differences in the mechanisms of the diseases that we're treating, the way they're being diagnosed. And I think that coronary disease is a major example of that, when it comes to women. And then also, if you look at trial participation, I think it is very hard, given the fact that from basic biology all the way up to clinical trials, we have insufficient insight into what difference there may be between men and women, and whether it is biology or socio-cultural. That's one of the big challenges of our times. And how to solve that, I don't have the solution to that, but I would say when it comes to comparing men to clinical trials, you'd almost have to do, you have to make sure that you have sufficient representation in those trials of both sexes to start with.
So let me pick
Alan, any thought on this?
Yeah, actually, let me bring in the remote audience, because there's some questions that have come in, and let me pick the second one first. And one of them relates to what Hanneke was discussing. What platforms are available for women making a difference? And are there any conferences recommended? I think we're really talking about it from a global approach, in addition to in the Netherlands.
Well, I do know that EACTS now also has a working group, Women in Cardiothoracic Surgery, that is organizing satellite events within EACTS and during their annual meeting. So that's what we have in Europe. Locally in the Netherlands, I don't know of any specific.
Ourania, can you talk to the US?
Definitely there's a lot of, the various societies, including ours, we really try to promote, cardiovascular care. There's a lot of, there is a lot of talk about the teamwork, as you know, or the hard team approach. And this is something that the society tries to promote more and more and more. And definitely, from the cardiac surgery arena, I can say that. And I know from the Vascular Society as well, but also on the institutional level, by creating the heart valve, team and the cardiovascular, team and the care. And it's just, by the end of the day, it's really better patient care. And really you create this global, because in 2021, you cannot really talk about boundaries. Right now, it's like the global cardiovascular network. And by creating a vision and see how we can improve patient care. And because, for example, cardiovascular disease is still the #1 cause of death in women in the US. That's an issue. So in order to make things better, we have really to be a little more focused in precision medicine, really identify differences between men and women, and at the same time, different disease processes. So that's, my thoughts on this.
Yeah, so the other part of this question is really about global approach to cardiovascular care. I think what they're getting at is, sitting around this table, we got vascular surgeons and we got cardiac surgeons. It's the same disease process, but there's not really a platform by which we all kind of get together to talk about global cardiovascular healthcare issues. Right? Maybe that's an initiative that the ISEVS could take on, actually.
No, absolutely. And I think the ISEVS is actually one of the, as you know, Alan, one of the main, I think, advantages of this particular society is that it's really one of the few societies that has interventional radiology, interventional cardiology, cardiac surgery, vascular surgery, all in the same at the same table. And that was the original philosophy of the society, that everybody, as you said, is like the same disease process. And everybody were here because the final beneficiary is the patient. And the only way really to find the best care is if all the minds comes together to have the best results. By me just thinking only about my own perspective, I can find one solution. But if we put all the brains together, there's no question that we're going to find much better outcome. And the patient is going to be the winner.
Back to you, Palma.
I was going to say, I actually, and along those lines, I think the pandemic has really changed everything. Going forward, we recognize that all the education platforms are going to be global. I know the major societies, the ISEVS, the SVS, we have global platforms that are going to be integrated with the World Federation of Vascular Societies. And I think that as we expand our network and our connection globally and virtually, and you've even had shows where people are learning virtual medical care and a lot of the innovative technologies to do things virtually, as you were showing on a recent ISEVS show you did a month or so ago. I think that the world is going to be very different now than it ever would have been if there had not been a pandemic. And I think that that's going to change the world globally. And I think the global care can come through the ISEVS. I think we can take that initiative and try to move forward on it, but it's going to go that direction regardless.
Yeah, and also understand, Alan, that there's no boundaries. It used to be like very strict, like this is one specialty, then you have another specialty, you have another specialty. It's not really, it's one patient. And by the end of the day, it's like cardiovascular process, cardiovascular disease, pathology. And we look at the patient as a whole. To do that, we do need people from different specialties that they can contribute, so can see the patient the way, and the disease process. So I think it's important. And definitely in 2021, the boundaries are not, at least they're not so well defined for a good reason. The approach is important.
I wanted to ask our panelists, we, Ronnie and I, are very involved in training young medical students and residents and fellows, and we're trying to get them interested in vascular and cardiovascular, cardiothoracic surgery. In your countries, what is the mechanism, or how are you building this relationship with the young trainees so that they're interested in vascular or cardiothoracic surgery? We have what's called the Vascular Surgery Interest Group, so the VSIG, and SVS will provide scholarships and bring medical students to the SVS so that we can open their eyes to how incredible vascular surgery is, or cardiothoracic surgery, depending on what side of this you're on. But how are you doing that, Hanneke and Kak Khee? How is that being managed?
Well, in vascular surgery in the Netherlands, you're trained first as a general surgeon. So the awareness and the interest is first actually usually by generating interest in general surgery. And we have a lot of interns that comes around and actually just motivate them, like bring them to the OR and show them how they do things and everything. And then by giving lectures also, they also organize lectures, especially for surgery interest medical students. And I give there every month a lecture or how to suture or make an anastomosis. And then they like it, and then they usually become first, a general surgeon resident, and then after that, you can see that they like vascular surgery a lot because we are a very enthusiastic group that educate them, and we have a lot of nice tools in our hybrid room, a lot of technical aspects next to very precise work of anastomosis, and indeed very good patient care that looks at the patient as a whole, because cardiovascular patients have a lot of other diseases as well, and it's a multidisciplinary approach that we use. So I see that a lot of surgeons, residents that were actually wanted to become a trauma surgeon changed after they had their internship at our hospital, and they wanted to become a vascular surgeon. So it's inspiration on the work floor, I think, and just the normal programs that we have, like the normal internships, and then the internships for surgery, and how to make them enthusiastic about that. Yeah.
So you don't have 05. You don't have the training program we have here, where they come.
No, we have 4 years general, 2 years vascular surgery. And then after that, you have to do a fellowship of 1 or 2 years. Sometimes you can right away in, but usually you're not skilled enough, so you have to do some fellowships. Yeah.
Maybe Trish can tell us from Canada, because you did the 06, right? So what was your thoughts?
Yeah, so I started our vascular surgery interest group with the toolkit from SVS, and that I think was helpful in terms of like actually having talks from the vascular surgeons at University of Toronto to introduce what vascular surgery is, because most of us, I think, we just kind of stumble upon it for different other reasons, almost serendipitously, but not because we actually know what it is. There's no dedicated programming for it. And then through that, I really participated in the SVS mentorship programs, which I really liked at the vascular annual meetings. They'll always pair you with, if you participate in these programs, they'll pair you with another vascular surgeon, usually a woman vascular surgeon. And so we started doing that at the Canadian Society for Vascular Surgery. So me and Dr. Laura Drudy, we both kind of headed up that initiative about having, a mentorship portion of it, a little bit of a lunch or a meet and greet amongst women, if we can. Obviously, numbers is an issue. We're a very, very small group. But yeah, we're actually taking a lot of the cues from the SVS.
Hanneke?
Yeah, well, in the cardiothoracic surgery in the Netherlands, there's only a few spots that become available every year, and we have a lot of people who want to become a cardiothoracic surgeon still in the Netherlands. So we don't have any specific programs to encourage them yeah, you know, to try and become, to get into training. What usually happens, it's through our medical curriculum. So there's a certain, I guess, certain parts of the program in our medical education that we provide within the Erasmus MC that allow students to come in and to take a look what it's like in the OR, what it's like in the ICU, what it's like on the ward. Some of those people actually say, hey, we want to do more. And we usually offer them first to do some research. So we make them interested in research related to the field, and then they can combine it by observing the clinic. And some of those people actually like it that much that they say, okay, we want to stay. And I think about 1 in 5 actually makes it into training. So we're not yet in like, please come over and pursue a career in cardiac surgery, because there's so few spots.
But it's the same in vascular surgery, Hanneke. But still, we want to inspire them, because if they become a general surgeon, then they become a trauma surgeon, or you know. So I want to have them in my vascular surgery program if they are good, of course.
Yeah,
but
the difference is you don't do general surgery. It's when you want to become a cardiothoracic surgeon. Of course, the first year is in general surgery, but then you go down deep. So most of the people actually get into a residency program. They also pursue a PhD on the side.
Yeah,
it's stiff competition. And I think it's very difficult to do that. And only, the most perseverant people actually make it in. And luckily, much more women than before when I started my career.
That's true. Yeah, we have the same in general surgery. It's very competitive. Yeah.
So here's an interesting question. Not quite sure how to phrase this one. Has there been a positive impact in equality for women in the workplace due to the virtual space being used more often? Do you think it's made any difference, COVID, and the fact that we're not all in here together? It's kind of a little different for surgeons because you can't do virtual surgery. But people are a lot more distanced than they used to be. Does that have any kind of impact on female equality?
I think that it's been allowing a lot more awareness of these. So now all of the panels that are taking place across the countries, it's advertised on Twitter, and so you see what's available. And then when women aren't represented on those panels, a lot of people will be very vocal about it, and then you learn about that, and so now more women are being featured by those panels, and I think that that's been a really positive change that I've seen, and it's usually through Twitter and those kinds of, there's a bit of activism with that, and in that way I think that there's some promotion of equality, which has been really nice to see.
That's interesting.
Absolutely. I think what happened is that people, I mean, definitely they're more aware, one. Two, they feel a little more able to speak up. So as Trish said, when they see a panel, if they don't like the panel, they're a little more, instead of being reluctant of saying anything, they're more prone to say something. And what happened is, I don't think that anybody wants to have a bad name, like an institution or a society, by just having a panel that is not well perceived by the majority of the members. So I think it's extremely important. I think actually did make, I don't know how much difference it made, but definitely increased awareness, as Trisha said. To me, there's no more attractive panel that just see different people in different backgrounds. So that's the best panel that I can have. So.
I completely agree, Ourania. I mean, that is something really that you can also voice these days through social media, much easier than it was when we were still sitting in all the different conference centers. So that's definitely an advantage. And also the people actually trying to do something about it, because I do know from my time in the board at the Heart Valve Society, it was a constant fight. And at some point in time, after a couple of years, then the men on the board would also say, okay, now Hanneke will come and moan again about the fact that we need more women and diversity in our panels. But that's something that I see definitely changing.
But Hanneke, really, I mean, I remember this from the heart valve. I mean, you've been a president in a meeting when you had really global leaders in cardiovascular, disease. And I think, remember of that meeting like 2 years ago, the whole panel was really very, very diverse. What actually this means is that to make a change, in order to make a change, the change really starts from the top.
Yeah.
And the vision of the people that they are on the top. I mean, we can try to make as many changes as we can, but unless there are leaders on the top that they have a vision and they really want to create people from diverse, to have a diverse society, this is not going to happen. And that's what, I definitely, I think you have done like a tremendous job during that meeting, and was actually obvious from the talks, and people can go back actually and check, but was, at least to me, was very obvious.
Yeah, well, thank you, Ourania. That took a lot of, it took like 10 years of preparation to get there, because, you have to advance through the ranks. And that's important, the image that you're sending out, the fact that you're a global community and everybody contributes from their own perspective and their own strength. The other thing, you then need to make sure that in the board that you have, that the next generation will take over. And so it's very important also as a leader to make sure that the people who will follow in your footsteps will also bring that vision further. And I think that's a big challenge, because we're still underrepresented, and it's very easy to go back to the old normal. That's what I find.
I think the awareness, I would agree, but still in meetings, when I am in a meeting or something, and I still can feel that there is a difference it's harder to speak even sometimes, you know what I mean? So if you're on a distance and a lot of people are talking with each other over Zoom and you want to say something, when I'm in discussion with my male colleagues, I can get through it. So it's also sometimes a bit hard over Zoom or over the internet to communicate, but I think it's a general thing, maybe.
So let me just add something in. As somebody who does a lot of recruiting, I want to build the best cardiovascular program in the United States. I can't do that if 40% of the people, the women who are basically coming into vascular surgery and cardiac surgery, if we can't recruit them, you cannot build a top-line program and bring in top talent if you're not trying to actively embrace, women who are coming into vascular and cardiac surgery. And so, there are different kinds of goals, but if as the leader you're trying to build the best program, you have to be able to recruit people like are on this panel, and you got to make a program that's appealing to them.
Yeah,
absolutely. I think we have to have actually this on our website, Alan. I think that was a great statement. I wouldn't agree more.
Yeah, and also what you say about offering them an attractive program. It's about recruiting women, but it's also about giving them all the opportunities to develop to their fullest potential. That's another challenge that's in there. We do see a lot of women still leave sooner than men are leaving the profession, and so I do also think that nurturing your talent is so important there.
So that's a really interesting comment, Hanneke. I mean, is there data about why they leave?
That's a good question. I've been asking, at least in my own hospital, because we see in Erasmus University Medical Center that a lot of talented women professors, different medical specialties are leaving the medical center. But we do not systematically have exit interviews, and that's something we need to take a closer look at, definitely. And I do think it has something to do with culture and perhaps not feeling as being at home as their male colleagues do and being included. And I do think that's one of the big challenges also for the leaderships, at least in the Netherlands, in our university medical centers.
Yeah, that's important. Maybe like an early burnout that we haven't really appreciated early on. But that's definitely is a concern. Yeah.
I think before we run out of time, I wanted to have each of the panelists comment a little bit about maybe just some clear obstacles that are still in front of women in the field, and then just some advice, just something that, you know, if you of a young trainee or even a more junior surgeon or physician came up to you and said, you know, could you give me at least a couple pearls of wisdom in your, you know, in your career that you would impart upon me, what would you say? Hanneke, would you comment?
Yeah, I would say, well, I do believe that women can lead from wherever they are, even if they're all the way down the food chain. I think support each other and build your posse. I think that's, and if you don't have anything nice to say, don't say anything at all. That's
good advice for us all.
Kak Khee, what do you think?
I think, first of all, don't let everything make you insecure, and you have to love yourself, and then hopefully the other ones will love you too, because it's an interaction, of course. So because sometimes I can see or feel that women are insecure about comments on the work floor, but just stay true to yourself and you know, love yourself, and if you don't agree, then speak up, but stay true to yourself, and you're as good as everyone else, you know, so you can achieve everything.
That's wonderful. Trisha, do you want to add to that?
Like I start from kind of echoing what Dr. Lumsden was saying, like, our specialties need women in order for it to advance. There's no way we're going to be, you know, the best we can possibly be without women being in our fields. And so when I talk to medical students about this, I'm just very clear that, you know, if you like this type of field, if you like it at all, you got to go for it. Like, you know, there are obstacles, absolutely, but things are changing and you can be a part of that change, and like, we need you. So I just really try to make, you know, I just want them to really believe in themselves and keep going forward and not give up just because of a lot of, you know, discouraging things that might happen along the way. And yeah, just being really positive about it. I'm so glad that I did this training program, you know, have the job that I have. It's hard, it's not easy, but I'm so happy that I did it, you know, and so I just encourage a lot of women to do the same.
Ourania, would you like to make some comments about that?
And usually the same thing that I say all the time, just keep moving to the right thing and you'll be fine. There's nothing like that can stop you. If you really have a vision and you want to do things, it's nothing that can actually make you not do it. So just help your colleagues on the way up and help your patients, and things will be fine. But you need to have a vision. I mean, you need to have a vision and you need to just go for it.
I would agree with that. Alan, why don't you make some comment about
I'm afraid to.
self-respect?
No, there's been a fascinating discussion, actually. And, you know, Hanneke talked about microaggression, and Ourania can testify to this. When I first came down to Houston, they didn't do microaggression. They just bypassed microaggression and went straight to the aggression, which I was extraordinarily proud of. And it was a pretty rough place. And when I look at the transformation that's taken place in Houston in terms of the culture, and, you know, the women who are now involved in the cardiovascular surgery world, it gives me great hope for much broader changes. If it can happen in the environment that existed here in Houston, trust me, it can happen, you know, elsewhere. And, you know, I think that with the kind of leadership of people like you've got on the panel, it's going to change for women. I don't worry about the people who are on this panel. They're tough enough and aggressive enough that it's going to work. But you wonder where the casualties are in people who are not quite as focused, along the line, and you may well be losing people, who are not quite functioning at the high level that these panelists actually are. And I think those are the people we want to really make sure that we retain in the specialty.
Absolutely. This is actually a very, very important point, that the casualties, and that we cannot actually lose there are quite a few people, that maybe they don't have the stamina, as Alan said, and the burnout is a little more prominent to them. So I think it's important.
All right. So I think we're getting near the end. Palma, you want to wrap it up?
Yeah. I want to thank our guests, and I'm always happy that this is also taped so that we can go back and rewatch it, because there's always very important points that are brought up by everybody on the show, and you're all so inspiring to me. I'm just so grateful to have you come on the show and have other women and other people, maybe young male trainees too, may be inspired. I think that we all just have to pull. If we all pull 110% and help each other, it'll be better. I don't think this world where it's dog eat dog and kill or be killed is sustainable anymore. We have to nurture the people. We all have times in our career that we don't feel as strong as others. And that's when our colleagues have to lift us up until we're okay again. And then we go forward, and then it'll be our time to lift somebody else up. And then we will go forward like that and become stronger and grow as a society and as a specialty. And it's just my thoughts on that. So that's really it. But stay tuned for our next show, which will be in May. More women in aortic surgery. So we'll be discussing that.
Thank you.
Thank you.
Thank you.
Thank you.
Have a great day. Okay.
Thank you.
Thank you.
Bye-bye.